Hello and welcome to today's webinar. And thank you so much for taking time out and being here today. My name is Ayong. I am the Marketing and Educational Seminar Coordinator here at NeoBiotech. And hello and welcome again. So today's agenda is very simple. I will introduce our topic and the presenter and also go over some communication tools, and I will make an announcement in regard to upcoming webinars and watch previous webinars and also how to receive your C credits at the end. So please don't leave and stay until the end. And our topic today is Sinus Lift, Crestal and Lateral Approach with Dr. Kent Hwang. And we are also strongly recommended to use the chat box right here to communicate with me if you have any technical issues and other than the topic. And we will have a Q&A session at the end. So please submit your questions through this Q&A box. And one thing I want to address is Dr. Hwang may not answer all of your questions since we have a short period of time. And let's have Dr. Hwang to start the webinar. And good morning, Dr. Hwang. How are you doing?
Good morning, everyone. How are you?
Good morning, doctor.
Yes, thank you for joining. I know that right now it's really some uncertain time, and I really appreciate you all joining me. I'm hoping that I'm able to provide some information that you could implement into your practice and help you out with your implant career. Okay, so let's go ahead and start right away. Because it is a reduced time, I want to jump in right away, okay? And so I'm going to talk about sinus lift, Crestal and Lateral Approach, and I really believe that you can do this. Anybody who puts a little time into it can do this. So if you need a little hand holding, I can definitely help you with that. So I am your colleague, and I will provide my email address so you can contact me at a later time, okay? And this is a little bit about me. For those of you who don't know me, this is who I am. I'm not going to go over this. This webinar is being recorded, so you could always come back and look at this later and see if it's any interest to you, okay? That's who I am, so just to get to know you a little bit better. But I want to start off right away to show you what I do and what we can do and what I expect that all of you can do. So this is just a case that's a combination of a Crestal and lateral combination case. This is one we did a while back, and we can see the patient came in here with complaint of upper left premolar, second premolar. Was in pain, it's mobile, and now she feels like she needs to restore that area. So she came in and we decided to do some implants. And so we could first see that the residual bone height is right there, and we're going to take out that number 13. So that's where it is. And the sinus, if we dry that out, that's what we're looking at. So we could clearly see that there's some deficiencies in the molar region for bone implant to be stable. So we recommended sinus elevation and implantation, but we did a combination of Crestal and lateral. And I'll go over the rules for when you should go to the Crestal or lateral, okay? And I apologize if I'm going really fast, but this is normally a 3 to 4 hour lecture for me, but I had to reduce a lot of slides, and so here we are. Anyway, this is a CBCT cross-section of the area that we're interested in. If you look at the number 13 area, you could see that we have a remaining tooth, and the residual bone height to the sinus floor, it looks like about 7.4, around there. And then number 14 area, about under 5 millimeters. And number 15 area, we have 7.8 or around that much, okay? So this is an intraoral view of that site. Obviously, nothing substantial there. That's the area we're going to work on. And if we lay a flap, this is what we see. We see plenty of width, okay? And if you could notice, the incision line on the ridge was toward the palate. This is so that we could just reflect one flap and get a clear view. We don't have to try to hold two sides, okay? And if you look at number 13, I didn't extend the flap that way. We're just going to do a crustal approach there with immediate extraction. So here I may use the lateral kit from Neobiotech to make an easy, simple window, circular window. This takes, after some practice, it literally takes about 5 minutes to do, okay? And it's very safe. And I put some bone graft, and I put it in there, and this allows me to lift the sinus membrane and have a safety zone for now drilling, okay? So I go in crustally and do some drilling. I know that the sinus membrane is really lifted because I did the sinus lift through the lateral window, and we put some bone graft there, so we have plenty of safety margin, so I'm not concerned about drilling into the membrane, okay? So after that, I place the implant, and number 13 is still there. After I place number 14 and 15, I go ahead and extract atraumatically number 13, and I denude, I clean out the socket as best I can, make sure there's no granulation tissue in there, and then I put the implant in. And you can see here clearly the number 14 side, that's where the blue cross line is, cross-section line. You could see that we have plenty of bone around that implant, and you could see number 15, it's a crustal approach. And so that allows us to get more stability, and we just lifted very little bit. It's about 2 to 3 millimeters, so that's fine. And then number 13 area, we did right into the extraction socket and went into the sinus doing a crustal approach, okay? This literally took less than an hour, okay? It takes me about 30 minutes to do all. And I'm not saying that you're going to be able to do that right now. From my experience of teaching hands-on and guiding doctors at their office and in our office, and have them do that, the first few times it's going to take an hour, hour and a half, maybe even 2 hours. That's fine, okay? We have a lot of the fundamentals. It's going to go fast, and literally this is going to take you half an hour, okay? And then this is another recent case. I did a full upper arch, bilateral lateral sinus elevation, and then I do a fixed bridge, and I divide it up into 3 segments, okay? And this is a patient that presented in July 20th, 2017. She has a lower partial and a fixed maxillary restoration, and it's failing. Obviously, you could see that it's failing, and now she has really no option except to do either denture or implants. And with the lower having remaining teeth, it supports the partial pretty well. So we decided to recommend she keeps that one, and the upper one, we're gonna go with the fixed, okay? And we could do a lot of things. There's always talks about all on 4, all on 5, all on so forth on the anterior segment. In the maxillary anterior, I find that it's pretty hard because the bone quality is not like the mandible. And so I've recommended bilateral sinus elevation and doing segment. So if we outline the crest there, that's how it looks like. And if we outline the right and left sinus, that's what it looks like. So you could see that because of the nudization after the extraction and so forth, there isn't very much residual bone, okay? You obviously have to do lateral sinus elevation, do bone graft. And there's patients, or there's doctors who are really nervous. They're scared, they hear about a lot of things. And actually, I love lateral. It's pretty easy and straightforward, very predictable once you get the basics, okay? So this is 1 year later, after we did the bone graft and the 6 implants. This is the way I placed my implants if I'm restoring the upper. I put 2 in the posterior and 2 in the front and 2 in the posterior on the other side. And I do a segment from first molar to first premolar, and then canine to canine, first premolar to first premolar on the other side, okay? So that was 1 year later. We took our time. We could see the bone level here, and if we are the sinus there, we have sinus going like that. So we have plenty of bone around the implant, very stable. So this is the restorations that's done. Same year in October. This is follow-up after she's been trying it for a little while also. And you can see that we didn't take out the partial lower denture on the x-ray, so you can see that that's there, okay? And it's very stable. She's really happy. She's really glad that she went with this decision. And this is the crest ridge, and the bone level is still stable. This is another year later. You can see that everything looks stable again. So she is, and this is just March of this year she came in. She's been coming in regularly if we need to. These are all screw retained fixed restorations. So we could remove these very easily and clean out whatever site that's bothering her and check on tissue, everything else. And you could see on this radiograph, number 6 position, you could see where the screw hole is right there, kind of. This was a full zirconia restoration, so that's why it looks so opaque. And the segment, like I said, is between the premolar and the canine on both sides. You could kind of see that here, okay? Okay, let's go over the anatomy really quick and go from there. That's important, okay? So we're dealing with the maxillary sinus. The shape of the maxillary sinus is in the shape of a pyramid. It's an air-filled cavity, obviously. Due to that, it reduces the skull weight. So if you imagine it was fully solid, it would weigh a little bit more. So, okay, we're a little lightheaded right now, but it's okay. It produces mucus, and that is to clean out any debris that we breathe in and don't let it get to the lung, okay? It affects our tone quality because the air it affects people's voice, okay? And also for us, most importantly, it affects how we're going to place the implant. And you'll find that this is my favorite place to do the implant. It gives me so much leeway once you know how to handle this, okay? This is an inner view of the maxillary sinus. It's a cross-section cutout of the skull. Whatever, let's see. So you can see here the arrow is pointing to a thin, no bone around the apex of the molar. And you'll find this commonly, okay, especially on the older patients. And but also you could see that there is bone between the roots, which is a root septum, which is right here, highlighted here and here. And that is ideal place to get initial stability. So when we're doing immediate extraction and placement, this is where we want to place it, which is ideal for position of the restoration in mind also, and initial stability, which is key to bone growth, okay? And then the other thing that we see here is the sinus septum, maxillary sinus septum, okay? And in this case, it's pointing right here. What that can cause is we might have to make multiple windows if we have to do bone grafting back in front of that, because if you do a window on one side, it's hard to have it go over to the other side, okay? That's pretty obviously. And then a lot of people are concerned about the illnesses of the sinus. The most common is the maxillary sinusitis, okay? And it's caused mainly by clogging of the ostia located near the posterior superior of the sinus, okay? It's a little hole where the mucus will drain to the back of the throat and clean out the sinus, okay? And if you have a lot of sinus, sometimes that gets clogged. The symptoms of a maxillary sinusitis is fever, pain, or pressure in the face near the cheekbone. And people may commonly also say that they have a toothache, or you may see runny nose, okay? And the treatment is usually a prescription of antibiotics, so that's pretty straightforward, okay? And then Schneiderian membrane is the lining of the sinus, and it's a mucoperiosteum with 3 layers. You have the epithelial, cilial epithelial, highlighted here with a little E, yellow E there. And that has cilia there that moves the mucus. And also you have the lamina propria, which is the middle, and you have the periosteum that lines the sinus floor and attaches the bone, okay? And the Schneiderian membrane is usually less than 1 millimeter, and it's thicker on smokers usually, okay? So there's variations in that. And then the advantage of the Schneiderian membrane is it has fewer blood vessels. And what that advantage is for us as a dentist doing the surgery is that it is pale in color because there's no blood vessel, not as much blood vessel. So we can differentiate between Schneiderian membrane and the blood and other things when we're doing the surgery and we're getting close to that, okay? And we always say when we're using a drill to get into the lateral window, we'll see a dark shadowing, okay? And then the other key point is it has fewer elastic fibers. And that means instead of stretching like a balloon, it'll just peel off. It peels off. It lifts off the floor of the sinus. So that allows us to elevate it off the floor and do the sinus lift, which is very key, okay? So let's talk about the blood supply to the maxillary sinus. It's coming from the division of the maxillary artery, the infraorbital artery, which is a superior part. We really don't need to be concerned about that because we never go up that high, really. And then the posterior superior alveolar branch, okay, PSA artery, and it's anastomosis. It branches off into intraosseous branch and then extraosseous branch, okay? So I'll go over that a little bit more, but and in this diagram, you could also see the ostia, which is the dark area in the posterior superior. That's where the mucus will drain, okay? And then risk factors for arterial bleeding during maxillary surgery. The first thing, the green is what I'm trying to show as a soft tissue. When we make a flat reflection, if we make a really high flat reflection, which I recommend, there's a risk of PSA artery incision, so bleeding. And when that happens, what you do is put pressure, shoot lidocaine with epinephrine in there with pressure, and put gauze and pressure in there. And if you happen to have CGF ready, you could do that. You could put that in there, and that'll help the bleeding because it has autogenous fibrin glue in there that helps the clot, okay? And then, so that's the incision part. It's the exterior branch that you have to worry about. And then when you're making a sinus window cutting into the bone, then you have to worry about the lower branch of the PSA artery, intraosseous, okay? So here is a cutout, and you can see this doesn't happen all the time, but this is a cutout. You could see that if we weren't careful, we could cut the blood vessel there. And if you do, once again, you have to put a little pressure, hold that down, and we'll control it. And like I said, if you happen to have CGF, that would definitely help. So nowadays, when I do any dental implant surgery, we do draw patient's blood and use the autologous material to help in healing, and it's a great thing, okay? It doesn't cost us much, okay? So the maxillary goes through something called pneumatization, okay, the sinus. And what that is when you extract the posterior maxillary tooth, the sinus kind of expands, okay, because there's nothing there. The expansion of the sinus goes toward the extraction site, okay. This you could see in the area here, the premolar. Usually you would expect that sinus floor to be much higher, but it dropped down because of the pneumatization. So if you look at the canine and the second premolar, the bone around it is much higher, okay. So the extraction happened a long time ago and the pneumatization occurred, okay. So this would necessitate us to do a couple of things when we do an extraction. We would definitely recommend that you do a bone grafting socket preservation or implant and bone graft at the same time, okay? So this is to preserve three-dimensional bony architecture of the sinus floor at the time of extraction. It's not only to do the width and height at the ridge, but when it involves the sinus will pneumatize and drop down. So to prevent that, you should do bone augmentation at the same time, okay? And factors to consider when extracting posterior maxillary teeth, like I said, we have bone resorption that happens if you don't do bone grafting. This is usually in height and width, not including the sinus also, but if you leave it alone, the sinus will pneumatize and go down. And another thing is if they have a posterior tooth to the extraction site, there is a mesial drift that will happen if you don't do anything, if you leave it alone. So that will cause a narrowing of the dental site mesial distally because of mesial drift of the posterior teeth. And so we always recommend a stay plate or a space maintainer for the patient who's getting premolar or first molar, and they have a posterior tooth to that. Okay. Maxillary sinus luminization without bone grafting, I just talked about that in the slide before, so that's that. And types of maxillary surgery, obviously there's a Crestal approach, which is going to come from the mouth going up, okay? And then there's a lateral approach, which is going to go from the side, okay? And Crustal approach is also known as a blind technique because we can't really see into the osteotomy and see what's going on in there. It's a blind technique. And also it's considered an indirect technique because you're really going by feel and so forth, okay? Having said that, what is the key to a Crustal approach sinus elevation? Well, obviously, it is sinus floor fracture going into the sinus without membrane perforation, okay? And goal of sinus bone grafting is to make bone, okay? That's our goal. We have a deficiency in bone, so we're gonna make bone. That's why we're doing the sinus elevation. And the key factors for bone grafting, well, bone, if you're putting in new bone, there's different kinds of material you have. Autograft, which is from yourself, okay? If we could collect bone from the patient at the time of surgery and put that in, that definitely helps, okay? It's free, it's the best material. Allograft is from the same species. So this is a cadaver bone from a bone bank, okay? And then xenograft is bovine from different species. So we usually use bovine, which is ox. Or then there's alloplastic material, which is synthetic. And the most common alloplastic material is hydroxyapatite because it does have osteoconductive properties. So that's a great material, but it just lasts forever up there, okay? And so if you had a choice, I would go in that sequence of preference: autograft, allograft, xenograft, alloplast. And you could also do combination, which is also a good idea because they have different properties in terms of turnover rate, okay? And for any bone to form, you need blood supply, you need nutrients, so you need a blood. And for the sinus, you have great blood supply from the porous nature of the bone material up there. And a great thing about the sinus, you also get BMP, bone morphogenic protein from the sinus floor, okay? Because we're not damaging that site. So when we actually lift the membrane, we're kind of irritating, but we're not damaging, and it induces the bone to start producing BMP there. And that'll help bone start growing faster, okay? Obviously, when we have particulate in there, we don't want that particulate to move around. If that particulate moves around, you get granulation tissue instead of bones formation, okay? So immobility of bone during the bone healing is very important. And then you have to choose a particulate size. I recommend a larger size, anywhere from 0.5 to 1 millimeter particulate size. And that is due to the blood, okay? If you have really small, fine particulates, that's gonna inhibit blood from flowing in there, okay? You need the blood to start turning over and making bone. So larger size gives it a little bit more space between to allow the blood to get in there. Cortical canceled bone, I use a mixture because cortical has a longer turnover rate. It stays there longer. Cancelled has faster turnover, but it's porous, so it induces blood to go in there better, okay? Maxillary sinus is perfect for all of these things. Bone graft preparation, this is what I do. I do CGF on all my patients, or PRF. This is the armamentarium. The thing you see in the center top is for vasolocator. It works by infrared. Dr. Jason Kim went over PRF, CGF really well. If you want to get into detail, I would recommend you to go back and review his lecture that he gave last week, okay? And so this is what I use. You use a median cubital vein or cephalic vein right there and right near the elbow. Most patients are going to be okay. If you do this phlebotomy, practice a few times, it'll come to you. It's pretty good. Some patients are a little bit more difficult, but practice will be fine. This is the centrifuge that I use. It's the same one that Dr. Jason Kim uses. It's by Metafuge. You just press one button and it's all set. And you get these two red and white vial tubes, and they produce two different consistency. This is a Claude Buffy coat that we use to make membrane. And you could squeeze that to make a membrane, or you could use it as a whole, as a clump like that. I use both clump and membrane, and the clump part, I use it as a tenting effect in the sinus. If you put that in there, it creates a space and bone will form in there, okay? This is sticky bone, like Dr. Jason Kim said. It's very easy to handle, and it's got all these growth factors in there that'll help the tissue and the bone to heal better, okay? So I also, if I'm using collagen membrane, I reconstitute that membrane with the CGF, yeah. And let's look at the sinus again. Advantages of the sinus cavity for bone grafting. The Schneiderian membrane holds that, isolates the bone. The more bone morphogenic protein lining the sinus will help bone form much better, okay? And the porous inferior cortical plate of the maxillary bone will give the blood supply. And interior cavity, it's a protected cavity. So if you put bone particles in there, when patients eat, when patients touch their face, things like that, it's not gonna put any pressure on that bone particulate. So the bone will stay in its place, immobile, allowing it to form bone. So very predictable, okay? What is the bone density of the maxilla? This is the D3. It's got 3 layers. It's got porous cortical and crustal, and then fine trabecular bone within, and then thin porous cortical bone in the inferior wall. Okay. Advantage, once again, of the bone is that it's softer. Okay, bone is softer, so it's easier to drill. You don't really struggle so much like the lower. Sometimes you have a patient that has super hard cortical D1 bone, and it's just heating up and hard to drill. So upper, it's hard to overheat the bone, but you can if you go too fast, but it's softer, much easier to work with. It's got plenty of blood supply, soft bone, so you could also do self-compaction by undersized drilling, which is a great thing. Okay. This is what I mean by undersized drilling and self-compaction, okay? And you have to take into consideration the implant design, okay? And Neobiotech IS3 is perfect. IS2, IS3, they're all perfect. They are tapered. They have very aggressive thread design, okay? So if you look at the left side, it's a more parallel implant, and you have to do a full-size drill, and you go in, and you can lose stability if you over drill a little bit, okay? And if you look at the right side, if you undersize drill, meaning that the yellow line is the drilling size, but the implant size is bigger, because of the soft nature of the maxillary bone, it will compact and stabilize, and you're going to get much better ISQ, more torque value, and so forth. So great advantage in the maxilla. Okay. There's 4 different kind of classification that Dr. Hall has come up with, and this is very good to know. So first class is doing an implantation without the sinus being involved at all, okay? You just have plenty of bone, so you just do it. And what's best to do is, like the drawing shows, if you get self-compaction, it's gonna help you. The second class is sinus involved without bone grafting. There's studies to show that you could do sinus lift without bone grafting. That's called the tenting effect, because you're gonna have blood coming in from the side and bone will form, okay? And then the third class is doing Crestal approach and bone grafting through the Crustal osteotomy. And lastly, class 4 is the lateral approach when bone added for sufficiently deficient bone there, okay? Importance of cortical fixation, and this is kind of to show you diagrammatically what happens. There's always a force and counter force, okay? So if there's a vertical chewing force and a lateral chewing force, the dark gray arrows is indicating. On the left, it's not involving the inferior cortical, so you just have compacted bone. The counterforce in the blue, you could see there's a vertical component and a 2 lateral component because of the center of rotation at the hinge point at the crown implant junction, okay? And then if you look at, the right side where it involves a inferior cortical plate, you have much more stability because that is also another cortical plate. As long as you could precisely measure and engage that cortical plate and the inferior aspect, you're going to have much better stability. Okay. Okay, so what happens when you're doing Crustal and you think you might have torn the Schneiderian membrane? There are several tests we could do. The most famous is the Valsalva Maneuver, which is basically you pinch the patient's nose and have them gently blow through their nose. Don't have them blow too hard. And you shouldn't see anything happen, really. Okay, no hissing sound, no bubbling coming out of the osteotomy, and so forth. If that happens, obviously you have perforation, and we can resolve that. Okay, easiest way is if you don't want to go, if you have a lot of bone, what I would do is if I had a CGF, I just put the CGF PRF clot right into the osteotomy and close it up. Okay, and it will heal. And I go back in later and then try it again, and that's usually fine. Okay? Or if you could do a lateral window to repair the hole also. When to choose crustal or lateral approach to the sinus. Okay. These are studies that there's been a lot of studies, but this is the one I always show. Toffler. It was in 2004 in the Journal of Oral Maxillofacial Implants. What they did was they looked at 276 implants placed with the osteotome technique, and overall survival rate as a result was 93.5%. But when they took into consideration the residual bone height, remaining bone height of the area, what happened is there was a clear demarcation where success rate was higher and lower, dropped quite a bit. So when they did implants in a residual bone site that was 4 millimeters or less, the survival rate considerably dropped to a level of 73.3%, which is significant. Okay, if you go above that, the success was much higher. So it was determined that implant survival rate was dependent on residual alveolar bone height, and the critical number here is 4. Okay, I like to go with 5 to be safer. Okay, so here is another study by Rosen. It's in Jomi in 1999. Okay, it's a retrospective report, and same thing happened. If you look at the highlighted green circle there, residual bone height 4 millimeter or less, and 5 to 6 millimeter, and you look at the percent survival rate, there's a huge difference. Okay, so that is a determining height. So everybody talks about 4 to 5 millimeters. I go with 5, so to be safer. Okay, so anything less than 5 millimeter in bone height, I would recommend lateral approach. Anything more than 5 or more millimeter, I would approach it with Crustal approach. And if you put a 7 millimeter or 8.5 millimeter implant crustally, that's only going up 3.5 millimeter. You don't even need to do bone graft if you don't want to. You could just put PRF in there, CGF, whatever you want. If you want to do bone graft, you can. They all work, okay? So the answer is residual bone height. RBH 5 millimeter or more, you do a Crustal approach. Residual bone height less than 5 millimeter, lateral, okay? This is my armamentarium. This is my basic setup. You have the Minnesota suture needle holder is not in this one. It's missing somehow. I have a little bowl where I put my used instruments, tools, and also I could use that for saline or whatever. Okay, and I have the P24 perios elevator, which is to the right of the blade holder. I really like that to initiate my initial lift, and then I use the regular periosteal to subsequently lift it more. Okay, and if I'm doing a lateral, this is a kit that I have. It's 4 instrument, this will resolve all my needs for lateral approach, okay? So if you want a list of those instruments, you could email me later. I could send you the slide and information and also everything you need to know about that. These are different blades that you could use. I usually have 15 and 12. That's usually the 2 blades that I use. 15 for most of the things. 12 is really good to go on the posterior and the posterior region. It's a little easier to cut. Okay. And here I have the bone. I use allograft, corticocancellar mix, larger particulates. I use PTFE suture. They're great because they have no wicking effect. They're kind on the tissue, and they hold knots very well. I can't say anything bad about it except that it costs a lot. Okay, and I use collagen membrane if I need to, but I love having free, at least to us, free CGF-PRF from the body. It has better properties also. But if I need to have a longer lasting barrier, collagen membrane, this is a little longer lasting collagen membrane that I use. And if I'm doing aggressive bone augmentation at the ridge, I have ZTI membrane, titanium membrane from Neobiotech. I use this also to do some crazy bone grafting. Okay. You also need the basic drill kit, the sinus kits and so forth, but you always need this, okay? And then I'm gonna go over the Crustal approach, innovative tools offered by Neobiotech Implant Company. This is what it is. SCA stands for Sinus Crustal Approach. It's very simple toolkit if you break it down into pieces. What you have is the key drill is the S drill, S-reamer, and it's called the S-reamer because you could see that the cutting surface looks like a shape of an S, okay? That's how it is, S-drill. And the S-reamer, the action, what it actually is evolved from cranial surgery. When brain surgeons are doing surgery on patient's brain, obviously they want to go through the cranial bone, but they don't want to cut into that brain, right? So they came up with a drill that cuts bone, but is safe on the soft tissue. And this is what it is. It's just miniaturized, okay? It's the S. And what happens in the S flute is bone chips collect in there and help to push the tissue. It doesn't cut the tissue, and the rounded edges also, okay? And so when you do use this, you could see this is a very shallow osteotomy, so you could see the thin bone disc that forms. And this is a video that is on a pig jaw that you could see the drill coming through. Okay, this is how the drill, and we're gonna do this in a high speed. Okay, it's not slow speed, high speed with irrigation. And just go through, and there's a sequence of the stoppers that we put in because of the shortened lecture. You can see that the membrane doesn't get damaged. This drill is spinning and it's already through. Okay, what happens with septums? No problem. It's actually great to have septums. It's more stable. So here we're gonna go right through the septum here with same result. It cuts the bone, but it does not cut soft tissue. So you could see that it's going through, and you can see here, it's through, but the soft tissue is not cut. And the stopper is here on the upper left of the kit, and there's 10 stoppers, okay? You're gonna increase the stopper is the amount of drilling that you're going. So if it's a 2mm stopper, that's how deep you're gonna drill in. If it's a 10mm stopper, that's how deep you're gonna drill in with that stopper, okay? So there's a lot of different sizes. How do you determine what size? It is because we're trying to get the inferior cortical fixation. We want to gauge that size, okay, and try to get this kind of situation. So there's 4 S-reamers. There's 2.4, 2.8, 3.2, and 3.6, okay? We divided into two different groups. The 2.4 and 2.8 is for regular fixture. That's like 4.0, 3.5 and 4.0 diameter implants. Wide fixture is anything above that, 4.5 and or larger, okay? And the way you choose between the two is if you're going to go deeper than 3 millimeter, then you're going to use the larger size of the two. If you're not going to go in any deeper than 3 millimeter, you're going to use a smaller size, okay? Here is a Crestal approach. We're going to do Crustal here. We'll have 8 millimeter, 6 millimeter, ideal case. Open up a flap here. You could do it with that flap also. Drill in with the stopper. You have to, this part is kind of key. This isn't in the sinus kit. It's in the stop drill kit. You want to open up the osteotomy a little bit after you start the initial drill. And that's so that it doesn't engage and you have the S reamer just going in and with some free space. And that also allows irrigation to go into the space to cool the bone, okay? And then you go through the sequence of stopper drill, bone graft, vertical augmentation, place implant. You get a great torque, okay? Because you're undersized drilling. And you have both inferior and superior cortical plate engaged. And this is after healing, final restoration, final x-ray, okay? This is a study that shows that by Lundgren, Anderson, Gualani, and Centerby, that shows that you could do bone, without doing bone grafting, you could do implant and raise the floor of the sinus, okay? And bone forms at that spot. Okay, sorry for going so fast, but we are on a limited time. I want to be able to answer some of your case questions also. Lateral approach, there's an innovative tool for that. It's a Sinus Lateral Kit. And this is how it looks. Here's the LS reamer. L stands for lateral, and S is the original S-shaped fluid in the design, okay? Excuse me. Let me get a drink of water. And you basically have these 6 drills over here. That's the LS reamer. And they come in different width, 6.5, 5.5, and 4.5 millimeter. And there's a stopper designed into it. That stopper prevents you from going any deeper, okay? And that stopper is set at 3.5 millimeter and 2.0 millimeters for all of these different sizes, okay? And here's a video of the drill going through, and it's safe, it's not cutting the membrane. Where do you create the hole? You want to create the lateral window depending on the radiograph and CBCT. You want to put the whole lateral window to the most inferior and anterior aspect of your sinus surgery, where you're trying to do it, and that would be right here. And this is due to, if you had a choice like here, would you put it to the right or left? The answer is the front one. And the answer is due to hand instrumentation. We're going from the front of the mouth. That's where the instruments are going in. So if you had opened up the window in the back, then to lift the membrane on the anterior, it's very difficult. You have to literally come from the back of the head, okay? So that's why it's important that you drill from the, make a window in anterior, inferior, okay? And also when you initiate the drilling, you have to make a perch. You have to start drilling on the edge of that first, because that is a flat drill. If you're putting the flat surface against the flat surface, you're not gonna have stability. So you're gonna turn that handpiece on the edge and try to make that little yellow line there where it creates a perch, okay? That establishes stability, and it allows the drill to stay in position. And then after that, you straighten out and push straight down, and that'll create a perfect circle. And there's a shoulder stop, like I said, that prevents it from going any deeper, okay? So it's the safety feature. And here you could it creates a bony disc that's attached to the Schneiderian membrane, and you're gonna be able to lift that area. And you're gonna instrument in there with the small mini instrumentation that comes with the lateral kit. And then there's the C reamer, which stands for core or cap forming, okay? And this is a little bit more aggressive. So this one, I would recommend you not to use it at all. It's in the kit, but I use it. It's not necessary. Okay, but for those who want to try, you can use it. What you want to do is start cutting into it, but you don't want to push it all the way through, even with the stopper, because it is aggressive. It can cut the Schneiderian membrane. You're going to do it in pumping motion and keep checking to see if you start seeing a graying or shadowing of the sinus. Then you could, what you could do is you leave it like that, and just like a bottle cap opener, you lift the membrane, bone graft, and you place it back. Yeah, but if you didn't put that bone graft back, would it be okay? Yeah, it's fine, okay? And here is a video of how you're gonna use the instrumentation. You wanna sound the bone. This is very important. You wanna touch the bone with the elevator and do that. You don't wanna do this where you take it off the bone. That'll cause tear, okay? And during the sounding, it also helps to stir the BMP, okay? So membrane tear, what can you do? You can use collagen membrane or PRF, CGF, okay? That's a whole different lecture. This is a case that came in, posterior right, had a molar taken out. This is the CT. You can see I outlined the area that's there. Very little bone there. We're gonna make an incision, flap it open, and I made you can see that the ovoid shape there. You can see the dark shadowing. That's the sinus membrane showing through a little bit. I lifted up. I had the bone is attached to the membrane. It's lifted up. That's the new floor of the sinus. Okay, put bone graft and suture, PTFE there, and then get primary closure. And that's the bone graft right at the same day. You can see where I made the window. That's the drawing of my future implant position. I have plenty of bone there, and it looks good, okay? Then they come back. You can see that the healing is beautiful. This is, the red line is where it was before. Now it's a new line. I made a tissue punch, go in there, parallel pins to see how the angle is. It's a little bit off. You can see that it's not straight. So I'm gonna start correcting that during the drilling procedure. This is one, this is another one, and the last one. It goes pretty quick because you have sufficient bone. Now it's all lined up, healing abutment place. This is afterwards. This is after healing. And this is how it ended up. Tissue looks beautiful. Did a pig cap impression. This is a great system by Neobiotech to do impression, second stage. And this is a final restoration, okay? And that's pretty it. I went so fast because this material, I didn't know if I was going to be able to make it in time. That's my email address on the upper right. I had to cut out so many slides. I wanted to give you so much more information, but unfortunately, due to the lack of time, and I'm sure if you're like me, it's hard to stay focused for a whole hour also. So you could reach me through my email and ask me any question, and I could send you photos or whatever you need to help you through this navigating this journey with the sinus. But I really do believe that sinus is a great area to work in. You have a lot of advantages once you know how to handle it, okay? Ayang, are you there?
Yes, doctor.
Okay, sorry I went so fast. I was so I want to open it up to questions, and if they need me to go back to slides, I can do that also.
Sure, I think there's a couple of questions in the Q&As.
Okay. Where? Let's see. Oh, stop sharing. Okay, here it is. Question. Okay. Question is there we go. Okay, sorry. Okay, Shari, why would not you have two of them be included in the lateral sinus lift of 14? It is included in the lateral. What you would do is lift up the 14 area and push it back. But I think you're talking about the first one. The reason why I didn't include the lateral on the 15 is because if we go back to that x-ray, you'll see that there's a septum, okay, between 14 and 15. So do I make a second lateral window or use a septum as a stability aspect and do a crustal? And that's what I chose to do on that one. I think that's what you're talking about, where I did a crustal on 15 and not on 14. The 14, I definitely needed to do a lateral, but because of the internal septum dividing the two chambers, I decided to do a crustal there, okay? And here, Harmony, couldn't you just do lateral approach only for all three? Yes, you could. You could have done that also, but crustal is very predictable. So I just, like I said, I think 15, you have to make another lateral if I wanted to do that. I think if you're talking about the first case, number 13, it was immediate. There's plenty of tooth. If I wanted to make a lateral for 13, I would have to go really high above that. So the window would be really hard to reach, okay? So the access window isn't favorable, okay? And then Shari again, do you use hydraulic lift portion of the Crustal approach? I have tried using hydraulic lift to Crustal approach also, but I find that hydraulic lift is really good. It takes some, what hydraulic is using water, okay? Water. Nyambi is a tool that uses hydraulic also. But hydraulic lift is if you're trying to do a lot of lift. I say if you're going to do a lot of lift, I would just go to do a lateral window. Crustal, I usually just do a small crustal lift, okay, 3 to 5 millimeter, okay. And you also have to look into the morphology of the sinus. If you have a flat surface in the sinus, it's very hard to do a large lift, because if you think about a flat surface and the Schneiderian membrane is just right on there, and you're trying to lift that, there's a lot of surface area that it can't lift off from. But if you have a situation where it's like a saucer, a cup shape, and there's a membrane there, and you lift that and it inverts, you can lift quite a bit, okay? So hydraulic lift, it works great if you're doing a lot of bone grafting, but if you're doing a little bit, it's not necessary, okay? And sometimes it takes practice also. So if you're pushing too hard on that hydraulic syringe, it can perforate the Schneiderian membrane if it's kind of thin, okay? Marda, to do any sinus procedure, is it done under general or all of mine are done under local. And even the lateral, literally, I'm doing these in 30 minutes, okay? I'm not trying to brag or anything. I like to have surgeries done fast. The shorter the surgical time, the faster the healing time, okay? So I like to plan out my procedures and go in really fast and get it done, okay? Clean cuts, fast surgery, okay? So no general anesthesia, all local, okay? And drug regimen following sinus surgery, I usually give 3 drugs to all my patients as long as they're not allergic to penicillin. I give amoxicillin 500 milligram for 1 week, 3 times a day. Motrin, I do 800, you could do whatever you want. Motrin also has anti-inflammatory, so it helps and pain, right? And PerioGuard to keep that area clean. Okay, so those are the 3 medications that I give after surgery. Before the surgery, 30 minutes before or whatever, you do chlorhexidine rinse also. Okay. Misak, how long do you wait before having patient wear stay plate? 2 weeks. Okay, I wait 2 weeks because of I have the patient come back in 2 weeks for suture removal, and at that time, after removing the suture, I could adjust the stay plate. Okay, you don't want to wait months. That's the only thing. You could wait a couple of weeks, a month, but you don't want to wait months. and then you're going to have mesial drift and so forth. EJ, Linda, do you give patient pre-medication? You can give amoxicillin 4 tablet 1 hour before, but I really don't, okay? Unless they have some pre-existing condition, I don't over-medicate patients. So I do not pre-medicate. I do a pre-surgical rinse with chlorhexidine. That's about it. Dong Park, do you place sticky bone into the sinus or just CGF? I do both. If it's not a big lift, I could just put CGF, the Buffy coat in its clot form instead of pressing it. Okay, when you press that clot, it extrudes some nutrients out of that, some important things there. So I like to put the whole thing in. That actually acts as a tenting effect, gives you more volume. So that's possible. So if you look at my lateral window post-op x-rays, you'll see some area looks like there's a void. And that's not because, in terms of bone, that's not because it's something else. That's a clot in there and that's holding up. That's why sometimes it looks like there's a void, but that will form into a bone also. Sticky bone is wonderful. Dr. Jason Kim, great lecture. I would say review that. Sticky bone makes it so much easier to handle. He says he incorporates that into the cost of the surgery. We actually charge the patient and we haven't had any problem with that, okay? It's up to you. Okay. Sticky bone is great. Okay, Raymond Kim, what is the RPM for lateral window? I do 1800, anything above 1500 RPM. It's fast, okay? You don't want it to go slow. Slow is causing more vibrations, so it'll jump around. You want to go high RPM, 15 to 2000 RPM. And you want to start it on an angle. You want to create a perch. If you go 1500 on a flat surface, that's just going to go straight across and cut up tissue. So you want to start on an angle, create a perch, and then upright it, okay? So high speed. Okay, Misan, in case of sinus infection, how would you control it? So sinus infection, what you could do is, it does happen. And it's usually patients who are using stay plate or denture, more so denture, okay? After you do the surgery, they put on the denture and it keeps pressing on the surgical site and creates an opening, and bacteria gets in and causes infection. You monitor it right away, put them on antibiotic, and follow up weekly. If it doesn't resolve, you open it up, clean it out, and do it again or something. But if you wait, I find that it's not a problem, a sinus infection, okay? I've had some, obviously, because I've done a lot. I've been doing it for over 20 years. Sinus infection, what I do is the one that had a lot of infection, I go open it up, clean it all out, rinse it out, clean it out, and then rebone graft. Had not had any problems that way, okay? Dong, any tips on lifting on medial wall? Yes, that is very important. Medial meaning the central. When you do a lateral window, you make a window and you see the Schneiderian membrane, and what the beginners will do is just push that back a little bit and put bone in there, and it looks like they have bone. And if you take a PA or a pano, it looks like you have bone. But if you take a CT, you'll see it's only halfway. It didn't go all the way to the medial wall, which is the important thing. And how do you verify that you lifted the membrane all the way up to the medial wall? After you do the instrumentation with the sinus instrument, going all the way to the medial wall, you have the patient just breathe normally through their nose. And what you should see is a ballooning effect where the Schneiderian goes up and down freely. If it's not going up and down freely, it's not going up, it goes sideways, then you know that you haven't gone to the medial wall. And you have to go back in there and use the instrument to go up the medial wall, okay? So that's a great question. This was something that I would show in a longer lecture. Thank you, Dr. Park. EJ, Linda, have you treated smokers and provided sinus surgery? Do you normally place healing abutments after sinus implant surgery? Yes, I've worked in a Korean practice. A lot of my male patients are heavy smokers, no problem smokers. They do have a little higher, research has shown that they can have more problem, but in my practice, I have not. So no problem doing implants on sinus. And I like to minimize surgery, so I usually do everything at once. I do bone grafting, implant, everything at once, okay? John Kong, do you do most of your lateral sinus lift using neobatica? The hole is kind of small. Okay, for beginners, I would strongly recommend using the neobatic lateral kit. It is very forgiving, very safe, and if you're just doing one tooth, it's very easy, okay? I wouldn't recommend you to tackle a full case. Obviously, you want to take baby steps. For that, I would definitely recommend lateral kit from neobatic. It's very forgiving. But when, like the full-on cases I do, I will make a big window. Dr. Smiler has a great saying, big surgeons do big cuts, okay? So a big surgery, you want to make a big cut. You want to see. The most important thing is being able to see, okay? Mizhan, Dr. Lim, how long do we have to wait before we can load the implant? Okay. Dr. Pratt did a lecture on immediate loading. We're finding that it's faster and faster, especially when we're using biologics like the BABE technique Dr. Kim mentioned, using CGF and so forth. And that is actually a very complicated thing, but you have to study, but you could load pretty fast if you know what you're doing, okay? In typical cases for beginners, I would wait minimally 3 months for, I'll go 2 months for Crestal, of course, because there's plenty of bone. But for lateral, I would minimally wait 4 months, okay? Dr. Mia Lee, hi. Do you pre-med? I think I already answered that, okay? No, not really, just rinse. Dr. Lim, how do you manage sinus infection after bone grafting? Like I said, if there is grafting infection, I go in there and clean it all out. It's just another procedure, but in all my years of doing it, not very many, okay? The first time it happened was scary, but really, once you do a couple, it's pretty straightforward, not a big thing, not very scary. What is your bone cocktail formula in the sinus? Okay, allograft, cortical canceller mixture, larger particular size. You can use a combination of mixtures, like Dr. Kim uses three bone types and then does 1/3, 1/3, 1/3. The xenograft, alloplast, hydroxyapatite I've used in the past. It has forever turnover rate, really, right? It just osseointegrate, it just stays there. So if you open that up, you'll see white particles everywhere. It doesn't turn into bone, okay? It just becomes part of the bone. So it holds the thing much better. But I found that in my experience doing allograft and autograft together is the best for me. I have no problem with that, okay? And I use CGF, PRF. It is great, okay? Dr. Linda Lee, what is RPM for Crustal? Once again, all of these are high speed, okay? High speed, 1500 to 1800, 2000 RPM, okay? John Inga, Dr. Inga, would you use synthetic bone in the sinus? I just mentioned I have used synthetic bone, hydroxyapatite. What happens is it stays there. Turnover rate it holds the space much better. So it's a great tent volume, but I don't use that anymore very much, okay? Only people that I use synthetic nowadays is religious reasons. For one, like Indians, I think I had some Indian patient who didn't want any other bone or something, and I use that, okay? Or some people have a preference. That was about it, okay? That was all the questions that I see on the Q&A. I hope that answered. Is there any questions that I was not able to answer?
Doctor, I think that is it. I think you answered all the questions, and I really do appreciate you answer it.
Okay. Yeah. So like I said, this is normally, I mean, I could just work on the Crustal for 4 hours and I would still have information. I have so many slides that I could have showed you on Crustal that will explain what happens. I have cases that failed, how to handle those, huge bone augmentations also. but limited time. So I would say visit my email or send me an email, okay? And I will do my best to answer all your questions. Okay, sorry I'm not able to answer all your questions, but I have another lecture coming up next week on beginners. So I hope you join me there.
Thank you very much, Dr. Dr. Hwang. And I just want to jump into the announcement. So here we go. So if you are interested in taking our webinars, you can find upcoming webinars in our website. Here's a website, www.neobiotech.usa.com. And I click on the webinar at the top, then you'll be on our webinar page. And starting on May, we will have 2 webinars every Mondays and Thursday. So total 4 webinars weekly. And the time is 1 in the morning from 11 to 12 p.m. It's Pacific Coast time. And then the another one is in the afternoon from 2 to 3 p.m. And all these courses are on first come, first serve basis. So please register in advance and reserve your spot. So we also have a great lecture coming up today at 2 p.m. with Dr. Lara on implant complication and failure. So please don't miss out this one too. And for Dr. And this is also this week's webinars on Thursday at 11 with Dr. Owen Train on anterior implant, and also on Thursday at 2 p.m. with Dr. Jeffrey Platt on advanced bone grafting made easy. So for Dr. Hwang's webinar, he will be lecturing on part 1, basic surgical placement and dental implant restoration of dental implants on Monday, May 18th at 2 p.m. And then the part 2 will be on Thursday, May 21st at 11 a.m. So do register those 2 courses on our website. Here is on our website at www.neobiotech.usa.com. And also here's more edit webinars. I will not go over all of these, but you will see it on our webinar page. So now you can watch our previous webinars. If you missed out some of these great lectures, you can go back to our website and click on the previous webinar at the top, and it's all free. You can watch all of these at the same time. So for CE, I really want to say thank you very much for those who stayed until the end. And as part of our ongoing effort to provide better continuing education courses, we really like to hear your feedback. So one of our sales rep will email you this link to complete. And this form should no longer take 5 minutes to complete. It's very simple and easy. And the form should look like this. And there's more questions in the bottom. So once you receive it, please fill it up and submit it as soon as possible. And I want to say thank you again for participating in today's webinar. We hope to see you again next time. So please, if you have any questions, feel free to contact me. And also contact Dr. Hwang. Here is my email address is young.chy@neobiotech.usa.com. And sorry about, we also have a limited period of time today, so we may not answer all of your questions. So feel free to contact Dr. Hwang as well. And I want to say thank you, Hwang, again for it was a great lecture, and also other doctors. Thank you very much for joining our webinars, and I hope you have a wonderful day.
Bye.
Bye-bye. Thank you.
Bye.
Thank you very much.